Good day, everyone. Today's topic will be about erythrocyte sedimentation rate, or ESR, and we'll also talk about the two methods used, such as the Winthrop and the Westergren methods. ESR is a measure of the degree of settling of erythrocytes in plasma in an anticoagulated whole blood sample during a specified period of time. This phenomenon is dependent on an interrelationship of variables, and these are the plasma protein composition, the concentration or amount of red blood cells, and the shape of these cells. RBC rouleau formation is enhanced by increased concentrations of fibrinogen or of alpha or beta globulins on the patient's plasma. ESR is directly proportional to the size or mass of the falling red blood cell and inversely proportional to plasma viscosity. Always remember that red cells that form rouleau in certain diseases are heavier and therefore have an increased ESR, while on the other hand, normal RBCs settle slowly because these cells do not form rouleau and therefore their mass is not increased. This test is a nonspecific indicator of inflammation or tissue damage. The erythrocyte sedimentation rate is commonly used as a general screening test, and although this procedure is nonspecific, it is one of the most commonly performed and ordered laboratory tests. In performing this test, the following specimen requirements must be observed. First, the sample must be collected in a tube containing sodium citrate or EDTA. 3.8% sodium citrate is the preferred anticoagulant, and the specimen must fill the entire tube if an evacuated tube is to be used. This is to achieve the correct ratio of blood to anticoagulant. The ratio is 4 parts of blood to 1 part of your sodium citrate. If EDTA is to be used as the anticoagulant, it must be diluted to the ratio of 4 parts of blood to 1 part of 0.85% to zero point 0.9 sodium chloride. Alternatively, blood can also be collected directly into a special sedimentation test tube containing the anticoagulant sodium citrate, as seen on the left portion of your screen. Blood must be kept at room temperature and must be set up within 4 hours. At 4 degrees Celsius, specimens have been reported to be stable for up to 12 hours. And lastly, hemolyzed specimens cannot be used. They must be rejected. Now let's try to differentiate between the two methods of ESR, which are Westergren and Winthrop method. Let's try to differentiate them according to the following parameters like equipment, anticoagulant, the method used in performing the procedure, the time, and the reference ranges or the normal values, which you will see in the succeeding slides. In this particular table, let's try to look at the equipment and anticoagulant used for both methods. So for the Westergren method, the instrument used is the disposable Westergren dispet system, which is either made of plastic or glass, and the length of the tube used is 200 millimeters. The bore of the tube is not less than 2.55 millimeters, and in terms of the markings, the top portion of the tube starts with 0 millimeters and ends with 200 millimeters, which you will see at the bottom of the tube with a division of 1 millimeter. For the Winthrop method, the instrument used is the Winthrop tube, which is also the same tube that we use for the macrohematocrit method. The length of the tube is 115 millimeters, which is shorter compared to the Westergren method, and the bore of the tube is 3 millimeters. In terms of the marking for the Winthrop tube, the left portion of the tube, which is characterized by red-colored markings, the marking starts at 0 at the top, and this marking is used to interpret the result for our ESR. Meanwhile, on the right portion of the Winthrop tube, which is indicated by white markings, the top portion of the tube starts with a mark of 10, And this portion of the Winthrop tube is used for interpreting the macrohematocrit reading. In terms of the anticoagulant for both Westergren and Winthrop method, the sample must be anticoagulated with EDTA or 3.8% sodium citrate. So this is how the disposable Westergren dispet system looks like compared to your Winthrop tube. And as you can notice, your Winthrop tube it's quite bigger but shorter compared to the dispet system. And notice the markings on your Winthrop tube. The top portion starts with 0, although in your disposable system, you cannot really see the markings. But the tube is longer compared to the tube used for the Winthrop method. Now let's take a look at the differences of the two methods based on the procedure. So for the Westergren method, we have two. First is the original Westergren method, wherein the patient sample is collected in a tube containing 3.8% sodium citrate or the anticoagulant present in your black top tube. For this method, no further dilution is required. Then we have another method under Westergren, the modified Westergren method, wherein the sample of the patient is collected inside a tube containing EDTA or the anticoagulant present in your purple top or the pink top tube. For this one, the sample of the patient must be collected in a standard size test tube having the dimensions of 10 to 12 by 75 millimeters. Invert the tube 8 times and then after which combine 2 ml of the patient's blood sample with 0.5 ml of 0.85% to 0.9% sodium chloride. So basically, the second method for Westergren will have to require dilution of the patient sample. For the Winthrop method, there is only one procedure for this one. You have to utilize the use of your Pasteur pipette to transfer the patient sample into the Winthrop tube and fill the tube up to the 0 mark. The two methods of ESR can also be differentiated based on time and the reference ranges or the normal values. For the time, for both methods, there is no difference because both methods will require that the sample should stand for 60 minutes or 1 hour before reading the ESR result. For the reference ranges or the normal values, we can differentiate both methods by looking at the patient population. So for the Westergren method, for male patients less than 50 years of age, the reference value for the result is 0 to 15 millimeters. For male patients older than 50 years, the result must be interpreted according to the normal value of 0 to 20 millimeters. For female patients less than 50 years of age, the normal value of the ESR is 0 to 20. If the female patient is older than 50 years, the normal value is 0 to 30 millimeters. For children, the normal value is 0 to 10 millimeters. On the other hand, for the Winthrop method, for male patients, the normal value is 0 to 9. For female, it's 0 to 20 millimeters, and for children, it's 0 to 13. Now we go to the stages of ESR. There are 3 stages for the settling of our red blood cells, and it starts with the initial rouleau formation for the first 10 minutes, followed by period of rapid settling which happens in the next 40 minutes, and finally the period of final packing which happens in the last 10 minutes of standing the sample. In total, the stages of ESR would take effect for 60 minutes or 1 hour. The methods that we have discussed earlier are manual methods for ESR determination. Now let's go to the automated methods for ESR determination. First, we have the VES-matic and mini-VES. So this one is a completely closed system for the determination of ESR, wherein 1 ml of blood is mixed with an anticoagulant, which is a sodium citrate, and this mixture is drawn directly into specialized Vacutech tubes, which also serve as cuvettes. The results are given or released after 20 minutes, and the reason for this is that sedimentation rate is accelerated by use of an 18-degree slat. The changes in the opacity of the blood column are measured as the sedimentation occurs, and the results are automatically read by an optoelectronic sensor. Another automated method for ESR is the Sedimat 15, which makes use of the infrared measurement as its principle. You can utilize this machine by placing 1 to 8 specimens randomly or simultaneously, and it provides results within 15 minutes. Next, we have the ESR Stat Plus system. This automated method for ESR determination is based on centrifugation, and it requires smaller required sample. It also has a shorter testing time, which makes it suitable for testing samples from pediatric patients. However, the disadvantage of this machine is that the samples or the results are difficult to replicate. We also have a disposable system for ESR determination in the form of the dispet. This one makes use of disposable plastic tubes that are safely plugged and made of non-wettable and non-absorbent material that provides automatic zeroing of the specimen. The ESR is prone to different kinds of errors. These errors may be inherent to the sample or could be due to technicalities in performing the procedure. In terms of the errors inherent to the sample, this may be due to the size of your red blood cells and the presence of plasma components. For the size of red blood cells, macrocytic cells or macrocytic RBCs results to a false increase in your ESR. Since macrocytes have increased surface area, they tend to be heavier and they settle faster. For microcytic red blood cells, they have decreased surface area, thus they are lighter, and they result to a slower fall of RBCs, resulting to a false decrease in your ESR result. Anemia, on the other hand, causes false increase in your ESR. In anemia, with the hematocrit reduced, the velocity of the upward flow of plasma is altered so that the red blood cell aggregates fall faster. Rouleau formation, like autoagglutination, causes clumping of your cells and thus they settle faster at the bottom of the tube, resulting to an increase in your ESR. Spherocytes or crenated RBCs also inhibit Rouleau formation and thus they decrease your ESR result. For the plasma components, acute phase reactants like your alpha 1, alpha 2, and fibrinogen often cause an increase in your ESR result. Any condition that elevates your fibrinogen, such as pregnancy, diabetes mellitus, end-stage renal failure, heart disease, collagen vascular disease, and even malignancy, may also elevate your ESR. The presence of your albumin and lecithin decrease the ESR result. Your cholesterol or cholesterol levels increase your ESR result. Protein abnormalities like hypofibrinogenemia and hypogammaglobulinemia, they also decrease your ESR results. The ESR can also be affected by technical errors. Here are some of the technical errors that may affect our ESR result. First, we have ESR should be performed within 4 hours from blood collection. A specimen that is too old or an EDTA anticoagulated specimen that is not processed and it's left at room temperature for more than 4 hours will result in crenation and sparing of red blood cells, resulting to a decrease in the ESR. Improper filling of ESR tube also causes a falsely increased ESR due to the presence of bubbles inside the tube. Over anticoagulation of blood causes a false decrease in the ESR result. We also have a tilt of 3 degrees can cause errors up to 30%. ESR tubes that are not placed vertically on the rack results in an increased ESR. Vibration, on the other hand, also increases the ESR result. In terms of the effects of temperature on the result, you have here increased temperature falsely increases the ESR, while decreased temperature falsely decreases the ESR. This slide shows you the clinical significance of the ESR result. So if the ESR is increased, the following conditions may be the reason why the result is increased, like pregnancy after the 3rd month, inflammatory conditions, you have Waldenstrom's macroglobulinemia, and other conditions. For ESR results that are low to normal, the following conditions may be associated to the given ESR result. It could be due to polycythemia vera, congestive heart failure, hypofibrinogenemia, sickle cell anemia, and others. And that ends our discussion on the erythrocyte sedimentation rate. I hope you have learned something from the discussion. Thank you for coming, thank you for listening, and have a good day.